BPS. Dr. Abhinav Singh has been a professor in the Department of PNC, Patna.
Good evening, Chairperson and the delegates. I am a rehab physician, and for last whole day, so this topic has almost been covered. But as a rehab physician, it is expected that I have to think out of box and go for a holistic approach. So by the end of my presentation, I hope the half truth, half sentences underline progression in pain. So you all will be able to decode it. So whenever we think about the pain, what is the pain? Pain is only confined to the bladder in ICBPS, or it has some other implications also. So whenever we think about a pain, there is a different dimension that we have to take care of. It is not only the physical or the pathology that is involved, but also the psychology that is involved. Psychology means, suppose someone is having the bladder pain syndrome, so he may be having anger towards the treating doctor, anger towards the God, anger towards the society, anger towards anyone. He may be having low mood, he may be having anxiety and lot of other issues. Socially, he may be isolated, he or she may have lost the job, he or she may have gone through other trauma or socially isolated, he or she cannot go for a party tonight, they can't do it because they have to have the urgency, they can't manage it. So social issues also come up, and again, if you have no one to blame, you can blame the God or other the spiritual things, that I am a spiritual person, why God is giving me so much of pain, or has I done some sin? So whenever we manage a pain, we have to keep all these 4 points in our mind. So most of the goal for any pain management will be, first in the BPS will be symptom relieve the symptom as soon as possible, and functional improvement. When I say functional improvement, it means that functionally patient has to be better. Better means with a new normal. When I say new normal, it is Martin Luther King's one statement: if you can't fly, you run; if you can't run, you walk; if you can't walk, crawl. But be functional, do something. So functional improvement with the new normal has to be done. And also, whenever we are managing pain in the bladder or in the pelvic region, we have to make sure that it has to have a preventive part, that it does not go into chronic pain sensitization. So the moment we are able to sort out these issues, the quality of life of the person will improve. So first line therapy will be behavior and lifestyle modification. When I say behavior and lifestyle modification, it includes the education part. It includes the timing. Timing means time voiding, when to have it, what is the fluid intake, and everything has to be taken care of with keeping the voiding diary in the mind. Another, the level of stress because of the disease that patient is having. Another thing that has been discussed all day is about the pelvic floor, hypertonic pelvic muscles are there. So you may agree, you may disagree, but something, that what exercise to be given, what therapy to be given. Everyone, either Kegels or biofeedback, any other exercise. The best exercise, what I think as a rehab physician, is that God has given us. I hope everyone is 18 plus. Is to have intimate relationship, is to have sex, because it relaxes the muscles. Once a person has an orgasm, it relaxes the muscles, especially the pelvic muscles all over, and it acts as an anxiolytic also. So this intimate relationship part that needs to be explored whenever we are managing a patient with pain, and especially the pelvic area pain. So that has to be always taken care of. It also improves the immunity, and it have other improvement also. Now second line therapy has to be, inflammation has to be controlled, or with the protection of the uroepithelium, and again prevention of the centralization, stop the pain going through the spinal cord and then to the brain. Now whole day we had been discussing about the amitriptyline. Amitriptyline is a drug of choice. Yes, amitriptyline is a good drug. It is an old drug, tried and tested, available everywhere, easily available drug, a cheap drug. But there is one more drug called mirtazapine that has come up. I think this is something that needs to be tried in the patients with bladder pain, because amitriptyline being an antipsychotic and the mirtazapine has an atypical antipsychotic. The benefit of this mirtazapine, if you weight functions or weight work, is more or less similar to that of amitriptyline, but it has a lesser side effect, and it also has a benefit of acting like a low dose opioid. Kappa receptor, it works at some point of time. With mirtazapine, if you are giving amitriptyline for long term, the patient do have this tendency of the side effects comes down, like tremors or arrhythmia that patient tends to develop, or urinary retention. All these side effects are comparatively lesser in the mirtazapine compared to the amitriptyline. So this is one area which can be explored in BPS. So third line cystoscopic intervention, whole day it has been discussed in detail a lot more. Then this neuromodulation, fourth is the neuromodulation. It is one of my favorite topic to discuss about. Neuromodulation, it can be by implanting, that is being done. Then again, it is a new area, lot of things needs to be explored. Only one side has to be implanted or both side has to be implanted, and there is one more option of percutaneous and a transcutaneous stimulation of the tibial nerve that is being done all over world, and it is a research topic, because even studies have been done on the transcutaneous, even the medial branch of the plantar nerve has been stimulated in overactive bladders, and it has shown good result. So this is the something which we need to think about in the long run. Immunomodulatory or systemic pain control again is a very important thing. Lot of things can be done. Morphine can be tried, or other systemic lidocaine. All these things can be tried. So we have to control the already tenozumab has been discussed by the previous speakers. Cyclosporine. These are the immunomodulatory things that can be tried as a fifth line therapy, and the sixth line surgical intervention and diversion, which the urologists are best persons to discuss, and they have already discussed whole day. So to summarize my part, I will just like to say, whenever we are managing a patient with bladder pain syndrome, BPS and IC, it has to be always individualized, never generalized, because every person has their different perception of pain. Pain perception is quite different from person to person. A person who is a hardworking, a laborer, has a different higher level of pain perception than someone who is not that hardworking, who is leading a sedentary lifestyle. So again, in the end, in totality, everything has to be taken care of: physical, social, spiritual and psychological. And again, progression in pain has to be managed with in totality, not only one aspect has to be taken care of. And most of the part, I think in the whole day, it has been already explained. Thank you.